So to start off the presentation, it's good to have some information about the virus itself. There are two distinctly different ranges of symptoms. Non-paralytic polio is the less severe form of the disease. Infected individuals would receive flu-like symptoms such as fever, sore throat, vomiting, fatigue, and stiffness or weakness. That would only last around 10 days. Paralytic polio is the more serious form. The initial symptoms mimic those of the non-paralytic polio. However, after just a week, the infected person could begin to lose their reflexes and start developing paralysis. The disease is spread from person-to-person contact and enters the body through the mouth, which infects the throat and intestines. It spreads through the contact of feces of an infected person as well as through coughing and sneezing. In turn, this makes unsanitary areas more susceptible to spreading the disease. There have been many disappointments and breakthroughs throughout history in accordance with the polio virus. In 1789, British physician Michael Underwood attempted the first clinical description of polio called debility of the lower extremities. In 1894, the first outbreak occurred in the U.S. of infantile paralysis due to polio. In 1931, Macfarlane Burnett and Jean McNamara identified poliovirus types 1, 2, and 3. In 1955, Jonas Salk developed the first inactivated injected polio vaccine. In 1961, Albert Sabin developed live oral polio vaccine. In 1991, the last case of wild polio virus was reported in the Americas. Between 2000 and 2002, both the Western and European regions were polio-free. In 2005, new monovalent polio vaccines were becoming available. In 2008, a new outbreak spreaded from Nigeria to West Africa. In 2016, 3 countries are still in an endemic state. Those 3 countries are Afghanistan, Nigeria, and Pakistan. The oral poliovirus vaccine is the most predominant vaccine being used in efforts to eradicate polio. There are many advantages to using this vaccine. It's inexpensive, safe, and effective while offering long-lasting protection, and the administration process doesn't require a health professional. And all these reasons are why it's a great vaccine to use in developing countries. There are 3 types of the oral poliovirus: monovalent oral poliovirus vaccine, the bivalent oral poliovirus vaccine, and the trivalent oral poliovirus vaccine. The monovalent only targets one of the 3 types of the poliovirus and is the most successful at targeting that specific virus. The bivalent oral poliovirus vaccine elicits an immune response against poliovirus types 1 and 3, but not against the second. The trivalent oral poliovirus vaccine contains a mixture of live attenuated polioviruses of all 3 types. This vaccine was withdrawn in April 2016 and replaced with the bivalent oral poliovirus vaccine.
Our group will now examine 3 of the many barriers to polio eradication in the country. The first of those barriers being political instability. Afghanistan, which for years has seen a decline in the number of polio cases, has suddenly seen a slight increase in the number of cases this year. Almost all cases in polio in Afghanistan are from 3 provinces in the country. In Afghanistan, the primary challenges to controlling polio transmission include poor security situation and inaccessible areas with geographical barriers. Children are most inaccessible, and health care workers face extreme difficulty in maintaining polio campaigns successfully. Not only are these problems in convincing people to get their children immunized, but there also exist problems with poor organization, corruption, and a lack of general determination among healthcare workers. Even the media and health activist groups until lately have failed to properly and effectively lobby and pressurize the government into doing so. In the nearby country of Pakistan, security issues also crop up in some regions of the country, often leading to failure in vaccination programs and repeatedly reinfecting one another due to substantial population shifts between the 2 countries. Our group acknowledges that the increasing militancy, political unrest, and lack of distrust and deteriorating security conditions are common denominators between the 3 countries where polio is still endemic, the other 2 being Nigeria and Pakistan. For several years, real and imagined wars have been fought with the West in politically fragile parts of Afghanistan. When the Islamic fundamentalist Taliban regime in Afghanistan was in power from 1995 to about 2001, it fully supported the GPEI, which is the Global Polio Eradication Initiative, and likewise other warring groups active in Afghanistan supported the initiative as well. Taliban is now surprisingly working to build trust among the general population and have allowed local people to engage in social welfare campaigns. Importantly, whereas the Taliban in Pakistan is a militant group that is dependent upon showing of power to maintain their control over a small geographical area, the Taliban in Afghanistan is potentially the government in waiting. This situation is fragile, however, because Taliban-like groups and pro-Al Qaeda forces are entering Afghanistan from other parts of the world. The withdrawal of international forces in 2014 from Afghanistan have also complicated the security situation in the country and has hindered the relatively successful efforts to fight against polio in the country. We will now examine some of the social barriers that are preventing polio eradication within the country. Many in Afghanistan have been impacted and traumatized in some way from the effects of war that have been going on for years. Some have witnessed firsthand the destruction that American drone strikes have caused on military and civilian targets alike. At the same time, fearful parents see waves of Western health professionals promising to help and cure their children. This distrust of Western armed forces have mixed with the distrust for Western doctors and has led to a major contributing factor of why rumors within the country surround Western doctors in the OPV. Some of these rumors around the oral poliovirus include that the vaccine is not halal and therefore should not be taken, or that the vaccine causes infertility or is poison. These are just a few of the social barriers that are preventing polio eradication within the country. And finally, we'll examine why economic instability is such a major barrier to polio eradication in the country. As we talked about above, the country has been experiencing ongoing war for years, and Afghanistan is heavily dependent on international military and economic assistance, and its living standards are among the lowest in the world because of the ongoing war. Rebuilding the healthcare system, while it is ongoing, has been an extremely slow process, and access to health professionals for the poor, and especially those living in rural areas, is very poor. Many within the country, even those who live near healthcare facilities, just simply cannot afford treatment and heavily depend on these non-government organizations who come into the country providing vaccinations.
Svea Clauser is an associate professor in anthropology at Middlebury College. She's well-versed in medical anthropology and public health. As part of a study she conducted, she volunteered in a campaign in Pakistan, another one of the 3 endemic countries, to deliver the vaccine. Throughout her fieldwork, she was met with much resistance, such as groups not finishing their duties, such as delivering the vaccine or transporting it, several days after they were supposed to be done. Even more surprising was the fact that in some areas that had gone unvaccinated, some of the doctors would simply pay people off to cover this fact up. Needless to say, the way the campaign was carried was very unprofessional. As for the health department, according to Clauser, it was a large and highly political bureaucracy. As such, the person in charge may or may not actually have had the expertise in the area of health needed, or may not have been involved in the fulfillment of the project as often as they should have been. If there is no guarantee that the leadership is involved, it is no surprise that the process of eradication would be slower than expected.
Now let's talk about the future of polio. The Global Poliomyelitis Eradication Initiative is led by the national government and is partnered with WHO, CDC, Rotary International, UNICEF, and the Bill and Melinda Gates Foundation. The goal for these groups combined is to eradicate polio worldwide. To achieve this goal, the GPEI has been working on updated vaccination policies, appropriate containment of the virus, certification of the eradication of polio, and planning for the transition of knowledge to help other health efforts. One of the bigger efforts taken is the cessation of the trivalent oral polio vaccination. The need for ending this vaccination is coming from the amount of cases that are seen with type 2 paralytic polio, which has been eradicated. So, the bivalent polio vaccination is being integrated, which only has components of type 1 and type 3 polio. The efforts for destroying all type 2 materials are safely containing it are underway. In the picture provided, it shows the number of 1-year-olds who received 3 doses of polio vaccine every year from 1980 to 2015. All reports were gathered using household surveys and facility reporting systems. This was published by the WHO's Global Organization Statistics. Afghanistan, Pakistan, and Nigeria are the main focus, but the United States is added to the graph to show the drastic difference. In conclusion, the long-term eradication goal of the polio virus for all Afghan citizens will only be met by a combination of political and economic stability, combined with a push by NGOs, GOs, and a unified effort to educate citizens on the benefits of OPV. The snapshot shown to the left is the actions being taken in Afghanistan for the month of August. The combined efforts of organizations will lead to the eradication of polio in the future.